So can everyone see my screen?
No, I see a green screen as usual.
I'm not sure what's going on between your screens. I can see Seba's screen very clearly.
Yeah, something is wrong with my
I'm not
computer.
sure. Yeah, probably. Let me try and so you can't see anything because I can see Seba's slides. Seba, can you try and put them on reading mode?
Okay.
Yeah, so reading mode is just to the left of slideshow.
Okay.
Just before that, just to the left. Yes, that one. Okay, Joseph, can you see them?
No.
Okay, I'll take over the screen from Seba and try to share my screen.
Sure.
So can you see my screen, Joseph?
Yes, now I can see them.
All right, we'll try and figure out what exactly is going on that you can see Seba's screen. Okay, so we'll proceed. I believe Seba, you are ready to start presenting. I think we'll move on, and others will let them in as we proceed.
Sure.
So welcome everyone to our Sunday Afro DX Clinic Unknown. So today I'm going to present a case to Dr. Joseph. So I'll be presenting to you a 31 years old female who presented a history of loss of vision in the left eye for 2 days, together with bilateral lower limb weakness for 2 days.
Yeah. Thank you very much, Seba, for taking your time from your busy schedule as a resident and coming here to present a case. And I'm so excited as this is the first case of the new year of AfroDX. The first case of the first year, I believe David solved it and I presented to him where just the two of us. And today, um, I'm solving it and Seba is presenting. So it's pretty nice. Um, so this is a pretty interesting complaint, and I'm excited because a neuro case. I love neurology, by the way. We have two complaints here, both of them neurology. Mm, Loss of vision can or cannot be neurology, but lower limb weakness, at the end of the day, it turns out to be neurology. So in solving any neuro case, I repeat this again and again, the most important thing to arrive at a diagnosis, two things. You put your time frame somewhere, and then you localize where is the disease. And the time can be divided into either hyperacute, acute, subacute, and chronic. Hyperacute is something which happens suddenly, like pop in seconds. We're talking about things like someone who is having a stroke. And then acute is something which happens over minutes to hours or to days. And then subacute is something that happens to maybe days to weeks, and chronic is something happening over years. So we are talking about an acute presentation here, 2 days presentation. And when it's acute, you have the differential diagnosis mainly two, an infectious process and an immune process. So at the end of the day, I believe if it takes me outside of that, I'll be returning back and back trying to figure out what is the immune process that presents with these complaints, or an infectious process for that matter. And then localization. An eye can be a problem of neurology or the problem of ophthalmology. Who should figure that out is the person in internal medicine. So you shouldn't think everything in eyes goes to those guys of ophthalmology. You're the one who can decide. Okay, you have a problem of neurology, or you have the problem of ophthalmology. And how do you know that? For example, this patient is having a unilateral visual loss. So you realize the problem here is either in the globe of the eye, or in the optic nerve before the chiasm. Because if you have the problem after a chiasm, a post-chiasmatic lesion of the optic nerve, you'll have problems in both eyes. But if it still sits in the one eye, you have a problem in the optic nerve before the chiasm, or in the eye itself. And in the eye, you have a lot of things. You have the cornea, you have the vitreous hammer, you have the retina. So everything in here can be affected. And if this problem is in the globe of the eye, usually it's the problem of the ophthalmology people. But if it's the problem of the optic nerve going back, usually it's the neurology problem. So Seba will tell us the history, and we'll figure out. But I believe, because we're solving here, we are internal medicine people, this has to be a problem of neurology, which it will turn out, I think, to be an optic nerve problem before the chiasm. Lower limb weakness. So Seba, this is unilateral lower limb weakness or bilateral?
So it's a bilateral lower limb weakness.
Yeah, thank you very much. So if you have weakness, it means you have a problem with the motor system. And if you trace the motor supply, it goes from the brain to the muscle. From the brain, you have the primary motor cortex, and then you go down, you have the corona radiata. It moves down, forms these tracts. They go into on the I think it's the brainstem, or the lowermost part of the brainstem, the medulla, and then they cross over, enter the spinal cord, from the spinal cord into the second order neurons that will get out of the spinal cord to the intermuscular junction, and then the muscle. So in that route there, something will be wrong, and then these patients will have um, weakness. But if you're telling me it's two limbs, now it's less likely that this disease will be sitting in the brain, unless it's a very rare entity in which something sits between the two lobes. Very rare it happens. I've never seen it. It's just read that it happens. But if you have two limbs are weak, then chances are you're either dealing with the cord, or you're dealing with the nerve, or you're dealing with the muscles. And all these have the qualifiers that we'll hear in the HPI. For example, if you hear they have blood and bowel symptoms, um, or a level of a sensorium involvement, we will know that this is coming from the cord. So more history, Seba.
Okay, I'll move the slides.
So the loss of vision in the left eye, it was of sudden onset, progressive. So initially it started as darkening of vision, then later on progressed to complete visual loss within 24 hours. So it was associated with an eye pain described as dull aching that worsened with eye movements. So it was not associated with discharge, tearing, redness, or itching of the eye, wrapping or distortion of the straight lines. There is no reported history of flashing light, floaters, halos, or change in shape of the object. There was no double vision, no loss of color vision prior to this. There was no pain on the jaw that occurred during chewing, no reported history of fever or headache, and the right eye was completely spared.
I think we should proceed, Seba, so that I can solve both of them.
So the lower limb weakness was of sudden onset, rapid progressive. So initially the left lower limb was involved at first. So it started as heaviness and progressed within few hours to a significant weakness. That the patient was unable to move the limb completely. And within 24 hours, the right leg was also involved similarly to the left leg. So this was associated with a tight band-like sensation on the lower back, loss of sensation up to the level of the umbilicus, bowel incontinence, urine incontinence, together with lightheadedness. No history of nausea or vomiting reported, no excessive hiccups, no history of excessive sleeping during the day, convulsions or loss of consciousness, no memory loss, hearing loss, no speech was not impaired, no difficulty in swallowing, no difficulty in breathing, and the upper limbs were not affected completely. So there is no history of diarrhea or recent upper respiratory tract infection before the onset of the lower limb weakness, nor any history of recent vaccination. So the patient takes mixed diets, is not a vegetarian. There's no prior history of joint pain, swelling, or skin hardening, dry eyes or mouth. No prior reported history of painless genital ulcer or previous history of genital discharge or any previous treatment of syphilis. No heat or cold intolerance or loss of body weight. No history of previous tuberculosis or known open TB contacts. So HIV status was reported negative, which was done about 3 months ago. No history of trauma to the lower back or to the left eye. There is no history of similar familial illness. There is no reported history of alcohol drinking or illicit drug use. There is no chronic use of drugs such as steroids or chemotherapeutic drugs. No prior history of exposure to inorganic fertilizers, pesticides, or herbicides. No history of working in the industries, mining, or saloon. And there is no previous exposure to radiation.
Okay, so I think I should start solving the lower limb weakness, and then I'll go to the eye. So take me to that HPI of lower limb weakness, because that's is the center of gravity of this case, and then the eye will be associated. So as I said, um, we localize, and then the time frame we already have it here. So if we localize this disease up to this juncture, so before I say anything, we have had a case here, a similar presentation like this. So if the person who joins here every day or listens maybe from YouTube, you already know what's happening. And Seba presented that case. It's the same thing like this, and at the end of the day, he had transverse myelitis. So that's the Lifrex diagnosis, and then to solve it completely, if you pause and realize where is this disease coming from, it can't be in the brain. As we said initially, it can't be in the brainstem, and then it has to be coming from it has to be coming from the spinal cord. Why? Because of most importance is the bowel and bladder symptoms, and at a point Seba told us of the umbilicus, that there is a level, a sensory level at the umbilicus. So there is no point. This disease has to be coming from the spinal cord. So localization for this done. So what's the thing that is happening here? The spinal cord can be compressed from things from outside and present as diseases. For example, if you have a fracture of a vertebral bone, for example, your vertebral bones are so affected, like they have malignancy or they have a TB, they fracture, they compress the spinal cord, and you present with those symptoms. Another is the infectious process. HTLV1 causes acute myelitis, or HIV, acute HIV itself can cause acute myelitis and present with something like this. Those are infections. And then I believe another thing that can cause as an infection, yeah, maybe other things will present as they come in. Uh, the next is trauma, but we have not been told that there is trauma here. Next is immune processes. So transverse myelitis itself, it can be an immune process, but I believe there are others. So of particular importance in a patient who has a eye problem and a spinal cord problem, everyone would connect the myelitis and the optic. They'll think of optic myelitis. But is it the only thing that happens? That's not true. There are others. Multiple sclerosis can also have the same picture. Again, these they go like three diseases. You have multiple sclerosis, neuromyelitis optica, and yes, MOGAD, myelin oligodendrocyte associated disease, something like that. So those diseases, if you mention one, you have to come up with all of them, three of them, because they will mean something later. So for me, I've localized this disease in the spinal cord. I believe it will turn out to be an immune process. As you're seeing, it is evolved within 2 weeks. And then an immune process of the spinal cord, transverse myelitis. If it turns out to be transverse myelitis, there have to be a cause. Infections, I've mentioned them. And then other immune processes like those NMOSD, MOGAD, MS. So if we go back to the eye, Seba is telling us this patient, if they move the muscles, if they move the eye, they feel pain. So what does that mean? It's either, we said the localization in this eye, it has to be from the globe, like the eye itself, to the optic nerve, but before crossing into the chiasm. But less likely this to be a process that involves the eye. And if it involves the eye, I have no much information because I'm not an ophthalmologist. I will take those patients to ophthalmology. But as a neurology case, and there is an associated symptom of neurology, lower limb weakness, this has to be the problem of the optic nerve. So the optic nerve can be inflamed, or they can have problem but no inflammation. You can have optic neuritis or optic neuropathy. These are two different things. For example, if you have compression of your optic nerve, that is optic neuropathy, not optic neuritis. But if you have pain, that is a process of inflammation. So we talk about optic neuritis here. And if we approach optic neuritis, the differential diagnosis, the way I approach it is, again, any inflammation. The optic nerve can be infected. There are cases of syphilis of the optic neuritis, for example, of the optic nerve, for example. I'm not sure about HIV because we were never mentioned syphilis. You should mention of HIV, but I'm not sure if it exists. But the one that comes easy to me is the syphilis. It can happen, and then other infections. Now I cannot think of them, but other processes include infiltration of the optic nerve. Sarcoid can infiltrate the optic nerve, and then immune processes, as we have mentioned. Multiple sclerosis can cause an immune inflammation of the optic nerve. NMOSD can cause that. MOGAD also can cause that. But among these, I believe NMOSD usually tends to be bilateral, but exceptions happen. But it can be bilateral. So if I connect this area on, but not to anchor, I put up there MS, and then because it's not bilateral, NMOSD has to be the last. MOGAT is rare, and the most common of these three is MS, by the way. Yeah, so that's where I am, and maybe we should hear more history.
So in the review of other system, it was quite unremarkable. In the past medical history, our patient was diagnosed to have systemic lupus about 3 years ago and was on regular medication of hydroxychloroquine, 200 milligram BD. So she was attending rheumatology clinic at Muhimbili National Hospital. And the latest systemic lupus erythematosus disease activity index was 0. So in the family and social history, it was unremarkable.
Yeah, so let me discuss a bit. There's a very important thing. The past medical history of lupus is very important in this case. Why? Because I forgot to mention this, but patient with lupus can also present with transverse myelitis. That's known. They can also present with transverse myelitis. What I'm not sure is whether patient with lupus can present with optic neuritis. That I have to check. I'm not sure about that. But another important thing, if you see a patient who is an autoimmune disease, because SLE is an autoimmune disease, they say birds of the same feathers tend to fly together. So autoimmune diseases tend to occur together. If they have SLE, they can have another presentation. They can have, for example, a thyroid disease like a Graves or Hashimoto. And then they can have the things that we have been talking here from MS, MOGAD, NMOSD, etc. So I'll keep this in mind. SLE can cause the presentation of the lower limbs. I'm not sure if it can cause the optic neuritis, but SLE as an autoimmune disease can be associated with other immune processes of the CNS that we've been mentioning. More history.
I think now we are moving to the exam. If you do not have any comments on the other components of the history.
No, I think I'm okay.
Okay, so I believe Seba is moving on to the exam now.
So in the general exam, our patient was fully conscious, febrile, ill looking, not pale, not jaundiced, no any oral thrush, no Aptar's ulcer. There was no angular stomatitis, no lower limb edema, and no peripheral palpable lymph nodes. So there was no stigmatas of chronic liver or kidney disease. Vitals were fairly normal, but had overweight with a BMI of 28.4 kilogram per meter square. So in the eye examination, in both eyes, there was no ptosis, no exophthalmos, normal eyelids, normal eyelashes alignment. The conjunctiva was translucent, the cornea was transparent, the anterior chamber was normal with clear aqueous humor, iris was normal with brown in color, and the lens was transparent. So in the systemic exam, starting with the nervous system examination, had normal higher centers, no signs of meningism. In the cranial nerves assessment, so the cranial nerve which was affected was cranial nerve number 2. So the right eye had normal parameters. The left eye, the pupil was circular in shape, about 4 millimeters in size, with a positive afferent pupillary defect. So the visual acuity was, our patient had only light perception. Color vision could not be assessed, and also visual field, also there was a limited assessment. Fundoscopy, patient had normal fundoscopic findings. So in the motor system examination, starting with the upper limb, so upper limb had normal motor system examination findings in all parameters. The lower limb, normal bulkness, but had hypotonia in the right and left, reduced power in the distal and proximal muscle groups in the right and left limbs. So the deep tendon reflexes had hyporeflexia in the right and left limbs. There was an absent clonus, and there was no, in terms of the Babinski sign, there was no upward going, no fanning out of the toes. Sensory examination of the upper limb was fairly normal, but for the lower limb, had absent crude touch sensation up to the level of T10, Pain was also absent to the level of T10. Temperature, fine touch were also absent to the level of T10, and vibration until to the level of the anterior spheric iliac spine. So our patient had a spinal cord sensory level at T10. Coordination in the upper limb was normal, and in the lower limb had a limited examination. So in per abdomen exam, positive findings were in the DRE, in which patient had a loose anal sphincter tone. Other systemic examinations were fairly normal.
Yeah, thank you. So that's a pretty well done exam. It shows Seba is a very good resident. Yeah. So again, the exam proves what we were like suspecting in history, and now we can see it through exam. What I remember, what you presented from the eye is there is an afferent pupillary defect of the left eye, right? So
Yes.
yeah, let me try to figure out if I can come up with the explanation, and everyone will understand here. So afferent pupillary defect, the pupil have afferent and efferent reactions. If you shine light in the left eye, light goes to the eye, into the optic nerve, to the brains, but when the information comes back, they come back in both efferent pupillary nerves. I think this is cranial nerve number 3. So if you shine in the right eye, the pupillary effect should be seen on both eye. That also should happen when you shine on the left eye. But when they say afferent pupillary defect, they mean you've shone your light in the left eye, but the right eye didn't have the reflex. What does it mean? It means the light didn't reach the brain. So wherever is happening in there, the exam that Seba told us, when I read it, it was telling me there is no problem with the globe, like the globe, the thing that the ophthalmologist deals with. So this is the thing of a neurologist. And in Tanzania, you mean an internal medicine and a neurology, it's a continuum. So when the globe is okay, your shining light is not going to the brain, it means the optic nerve is affected. But if you go and shine light on the right eye, you will see the left eye pupillary reaction, which means in the right eye, the optic nerve is intact. Light passes the optic nerve, going to the brain. When it comes back through the oculomotor, they both react. So this exam that Seba is doing is telling us this patient is not seeing because the optic nerve is affected. And because of that pain, we know it is not an optic neuropathy, it is an optic neuritis. It's an inflammation of the optic nerve. And if we move forward and try to solve the exam, the motor exam, we've already been suspecting that this patient is localizing in the spinal cord, and it proves here. But one might ask, the spinal cord is the upper motor neuron. If you have upper motor neuron disease, you have to see everything up, up, up. Like you have to see hyperreflexia, you have to see an upgoing toes, a positive Babinski, you have to see clonus, but they are not here. Why? The reason is the time is not yet. We are still in the acute process of this disease. The same applies when you see, I believe you have seen many patients with stroke. When they come in, you tap the limbs, it's hyporeflexic. But when you go to the clinic, they're attending there for maybe 1 year, 2 months, 3 months. The hyperreflexia, you see exactly this. So this will not take us away from what is happening here. This is a disease of the spinal cord, still acute phase. That's why we are seeing like hyporeflexia picture, but it doesn't, it shouldn't take you away. And the most important thing is the spinal level that Seba told us, the T10, and the DRI that showed a lax anal sphincter, plus the symptoms, bowel and bladder. So there is where we are. So what am I thinking now? I'm having a disease of the spinal cord and a disease of the neuron. The presentation of 2 days has to mean it says infectious or immune. I'm thinking of more immune because I cannot think of infections that will choose one eye and affect the spinal cord like this. And in that category, I will have number one on top there based on epidemiology and the patient being having one autoimmune disease and being female 30s. Multiple sclerosis as number one. But if you mention multiple sclerosis, you have to mention other things. And these include NMOSD, neuromyelitis optic spectrum disorder, and then MOGAD, myelin oligodendrocyte disorders. In the later, Seba will tell us like whether they were able to send the antibodies, or if we have just the imaging. There are stuff we can look at the imaging and try to tell one from the other. So maybe we should move on, Seba.
So coming to the part of investigations, so a complete blood count was done, which had normal parameters. The renal and the liver function tests were all within normal range. Serology was negative. The HIV serology and the hepatitis, together with syphilitic VDRL, was also non-reactive. Thyroid profile had normal parameters. So lumbar puncture was done to this patient. So macroscopically, it was a clear fluid with normal CSF opening pressure. Biochemistry had elevated protein. Glucose was within normal range. Cell cytology and differentials were not done. The CSF oligoclonal bands were also not done. For the part of microbiology, the AFB was negative. Culture had no any growth, and Indian ink, there was not any growth of the encapsulated yeast. Then coming to the imaging part, so brain MRI had normal findings, no any lesions in the brain, specifically the preventricular lesions. For the part of spine, MRI was done, which had longitudinal extensive transverse myelitis, together with cord expansion, also with contrast in increased contrast enhancement.
Yeah. Thank you very much. This it's a nice case. It's also called bread and butter cases, but they're so nice. They remind us a lot. So let's go to the CSF that is saying there was a raised protein, but in normal cells. So this is what they call albuminocytologic dissociation, because if the CSF is inflamed, you have to see both things coming out. The cells should go up and the protein should go up, but only the protein is going up, the cells are being low. This proves
So
this.
the cells were not done. Cells were not done. So
Okay. Yeah.
yes.
Yeah, okay. I don't know. So yeah, that's very nice. So if the cells were done, and if the picture is what I'm thinking in my mind, I expect something like that. The albuminocytologic dissociation, that you see in normal cells and then elevated protein. You realize you are dealing with an immune process. If both of them are up there, you have to think you are dealing with an infectious or a neoplastic process. That's unfortunate that it was not done. Another important thing is the labs are normal as usual in many neuro cases, and then that MRI. You know, the MRI of the brain is important because it has tried to 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 make MS less likely by not seeing, because even if you present with a spine disease, if you have MS, that's why these intelligent doctors image the brain because they can see something and think this is MS. Uh, you can have the typical lesions that are present in MS, even if you're presenting with something else, like this patient is presenting with the cord. So someone might be asking, why are they doing an MRI of the brain? That's the reason you want to see the characteristic lesions that we see usually in MS, and these are periventricular lesions. I think the disease is the name is Dawson fingers. Dawson fingers, yes, Dawson fingers. And then they are not there, which means, well, maybe less likely, but not impossible. But not impossible. But I would go back to the neurology, to the radiology, and ask, what are they seeing on the cranial, on the optic nerve, because they can see it. If it shines a lot, and you can say it's inflamed, and then it proves what you're talking about. And then if you come to the spinal cord now, that they did an MRI of the spinal cord, they saw a transverse myelitis. Now, that's very important. But Seba is not telling us one thing here, which I use to tell apart. Up, as of now, I'm thinking of only three diseases here. This got to be a multiple sclerosis, a neuromyelitis optica spectrum disease, or MOGAD. Now, how do I tell these three? In this country, maybe you can't find these antibodies and send them, because you're seeing in the CSF they didn't even do the oligochronobands. But you can try to dissuade one between the other. So if your MRI shows more than three segments, affected more than three segments, for me MS is out. So it has to be the other two. So Seba, how many segments were affected, like the spinal segments?
So there are almost 5 segments that were affected.
Yeah, so five segments. So if five segments, MS usually within three, either one or two. So MS is out. I'm remaining with only two diseases, MOGAD and NMOSD. This will be hard to tell these apart because NMOSD is more common than MOGAD, but you have to send the labs. You have to send the aquaporin 4 and then anti-MOG antibody to tell them. NMOSD usually presents with bilateral optic neuritis, but it is not always. So could this be MOGAD? I will never be able to tell which is which. But if I go for the epidemiology, NMOSD is more common, I'll put up there. But if I go to the presentation, the one which present with bilateral is an NMOSD. The unilateral got to be MOGAD. So if these diseases, I will never be able to tell you, Seba, which is which, until maybe I send the labs, aquaporin 4 and anti-MOG. But to complicate the matter, these things, there are also entities called, maybe you have aquaporin 4 negative NMOSD. That's so hard. If I reach that area, I send this patient to maybe neurology to figure them out. But maybe I hear from what you guys came up with.
So aquaporin's autoantibodies were done to this patient, and they turned out to be positive.
Yeah, if they're positive, then this got to be an NMOSD and not a MOGAD. I think we should proceed. I've seen your diagnosis, by the way.
Okay, Seba, where do we go next? We reveal the diagnosis.
Yes. So I think that will thank you for your very a critical approach way to go around it to be neuromyelitic optica spectrum disorder, which is the NMOD.
Okay, maybe Seba, let's proceed to your teaching points, and then
Yes.
we'll come back to Joseph for reflection.
So yes, some few learning points regarding today's topic. So NMO, which the other name is also David's disease or syndrome. So this is the rare autoimmune disease of the central nervous system. Typically, usually it affects the optic nerve and the spinal cord. So it's a demyelinating disorder, which affects the myelin sheath of the central nervous system. So it's predominantly more in women compared to men. Same picture as most of the autoimmune diseases. So the ratio is about 9:1. So typically it's in the arises during adulthood, as opposing to possible MOGAD. MOGAD is more common in younger patients, adolescents, together with the young adulthood, compared to NMO, which has the peak in the 3rd to 4th decade of life. So the prevalence is about 0.3 to 10 per 1,000 populations. So African American, or generally individuals in the tropical region, are more affected with the NMO as comparisons to multiple sclerosis. So there's this kind of a geographical distribution, a disease mapping, which usually says that NMO significantly common in the tropical regions, but multiple sclerosis, as you go farthest away from the equator, that is when you approach the poles, that is when the extent or the rate at which multiple sclerosis becomes more common. So it's usually sporadic, but there are some few familiar cases that have been reported. Limited data suggests that there are possible genetic variants in the major histocompatibility regions that may be associated with NMO. So patients who are having an underlying autoimmune disease, for example, systemic lupus, as our patient had systemic lupus erythematosus, although our patient had a very low disease activity, but still, even when the underlying autoimmune disease has attained a possible remission, so it's possible to have another autoimmune on top of the primal autoimmune condition. So other autoimmune conditions that has been associated with NMO is Sjogren's syndrome, the myasthenia gravis also. So in terms of clinical cause, so we have two major forms. So there is a monophasic form, which an individual usually have a single attack that may last 1 to 2 months. So usually males and female are affected equally in this monophasic form. And one thing which may also give you a clue to differentiate in terms of clinical presentation between NMO and multiple sclerosis. So usually NMO, the first episodes present with a severe form of transverse myelitis, while for multiple sclerosis, usually the first episode of attack or flare is usually mild, and with secondary progression, that is when the disease becomes more severe. So NMO can also have a relapsing form, which we commonly see in patients with multiple sclerosis. So they also present with a periodic flare-up with some recovery and another surge later. and the relapsing form is more common in females, about 80%. So there are 6 core syndromes depending on the location. So the most commonly affected areas is the optic nerve, the spinal cord, and the area postrema of the dorsal This is the chemoreceptor trigger zone, which controls the nausea and vomiting center in the brain. So the patient can also have other brainstem region lesions, also the encephalon lesions and the cerebrum lesions, but the most common one, it's usually optic nerve, so they present with optic neuritis, spinal cord, presenting transverse myelitis, and this transverse myelitis, as Dr. Joseph has said, is usually longitudinal extensive transverse myelitis. Also, they present with an area postrema, so they intractable nausea, vomiting, and hiccups. But that was absent for our patient. Our patient had classic optic neuritis together with transverse myelitis. And this transverse myelitis was in the cervical region, and this is the most commonly area in which they get the transverse myelitis in about 70% of the cases. Also occur. So when they occur, patients can present with oculomotor dysfunction, hearing loss, vertigo, dysarthria, but all of these were absent in our patients. So these features alone may not initially be able to be distinguishable from similar syndromes in multiple sclerosis. There's an international consensus for diagnostic of NMO. So there is 2 modalities of diagnosis. So the first modality is whether you have aquaporin 4 autoantibodies, and the second diagnostic modality is when you have absent aquaporin 4. So at least one core of the clinical characteristics, our patient had 2 of them, which were optic neuritis together with longitudinal extensive transverse myelitis, and also aquaporin 4 was positive in our patient.
Next slide, Seba.
Yes. Dr. David, you can move to the next slide. So this is the slide which summarizes the management for patients who are having a neuromyelitic optica spectrum disorder. So usually the first line of treatment is PASS therapy with IV corticosteroid using methylprednisolone, so 1 gram for 3 up to 5 days. Then there is also role of plasma exchange in patients who are having poor response despite receiving IV corticosteroids. So after the PASS therapy for 3 up to 5 days, there is a role of maintenance with prednisone therapy, oral prednisone therapy, about 60 milligram per day with a time frame of 4 to 6 weeks. But there is also a role of addition of agents such as methotrexate or azathioprine. So when all of this they've been used and then there is no significant improvement, usually there is a role of use of other agents such as rituximab therapy.
Okay, Joseph, any reflections from you?
Yeah, this was a very nice case, and I should applaud everyone that was involved. And it kind of eye-opening that we can send the aquaporin 4. This is pretty impressive. And so I learned something. I read a lot of up to dates, and so my my understanding of this disease is biased now. I realize to the west. And when Seba mentioned that as you go away from the latitudes, yes, MS goes down. That's very true. Now it came back to me. And maybe when I was there, I was saying epidemiology, MS have to be the first one. I meant from these literature that I learned. But through this platform now I'm learning also, okay, around here, maybe NMO should be above MS when you see something like this. But yeah, well put case, very good history, and exam findings and the teaching points are amazing. Yeah, I saw Shani Abbas's comment, very good, that also concerned of that thing, the radiology. You know, these radiologists can forget maybe to mention something, but if you go back, ask them, they look again, they'll see. Uh, they has to see the inflamed optic the optic neuritis that is there, because we are seeing it in the clinical presentation. Yeah, thank you very much, Shani, and everyone else.
Okay, thank you very much, Seba, for the presentation, and Joseph for discussion. So, Seba, there are questions from Shani. Did you do OCT or VEP for this patient?
Yes, I think that was supposed to be done to these patients. I think that was the area for improvements. That in cases like this, when you highly suspect that you're having optic neuritis and the conventional brain MRI does not show any sign of possible inflammation in the optic nerve, then these are the patients that we are supposed to be candidates for optical coherence tomography. I think that is the learning point, and also it's a point of emphasis in cases where you really suspect this, then OCT has to be done. But for a patient that was not done.
Thank you, Seba.
Yes.
So
one more comment, Dr. Joseph, as I reckon about what you said. So NMO, majority of the NMO, usually it's bilateral presentation. Almost about 70 to 80% of NMO usually they present with bilateral optic neuritis, but there is a low percentage of about 20 to 30% that may have a unilateral presentation, although it's not common in NMO as comparison to multiple sclerosis.
Sure.
thank you very much. So we are just on time now. If there is anyone with any comments, any questions, anything that you'd like to share, if you'd like to share your experience or anything, you're welcome in the few minutes that we have.
I think Dr. Shane should say something. I remember he had presented almost a similar case about, if not 2 or 3 years ago, of a possible case of NMO.
Yeah, sure. I think Shani Abbas's case was about Mogad, and would love to hear from him. But I see a hand from Kazaura. Kazaura, you are welcome.
Thank you very much. Thank you for the nice case. I just want to know the outcome of this patient, and he was kept on what medications, and how did the patient improved?
So this patient, we passed this patient with IV methylprednisolone. He received 1 gram OD for 5 days, then about 60, then with continuation with prednisone 60 milligram OD with tapering form for 4 to 6 weeks. On top of that, azathioprine was also added. So in terms of prognosis, our patient had a very severe first attack, which was also associated with an underlying autoimmune disease. All of these are markers of a very poor prognosis in our patient. So in terms of neurological response, until now, motor symptoms have not improved completely, still the same. Same for the sensory symptoms, blood and bowel function also still the same. And ocular response, still patient is having only light perception. So in terms of the prognosis of the disease, usually about 1/3 of the patients may have permanent disability completely, and they may not recover completely, especially when they have this kind of a severe first attack and they have an underlying autoimmune disease. So about 1/3% of the patients, they may recover with very little functional deficits, and 33% may have moderate functional disability. So our patient is had very rapid onset, complete paraplegia, that is within 24 hours. Our patient had completely developed paraplegia, and within 24 hours had only light perception. So these are all features which are poor prognostic marker in our patients. So this is almost the 3rd month and there is no recovery. So usually most of the recovery occurs within the first 3 months from the onset of the symptoms. And if the patient does not recover from the first 3 to 6 months, usually recovery is highly unlikely. So the prognosis for a patient is, until now, we can at least say that it's a poor prognosis.
Sure.
Thank you. That was a nice case, but very unfortunate.
Thank you, Kazaura. Now, Shani Abbas, can you share, at least in summary, the case that you presented?
Thank you. I hope I'm audible. Hello, can you hear me?
Yes, we can hear you, Shani.
Yes, yes.
Yeah, so I had a similar case when I was a resident at Muhas. I think I presented it into the grand round. Actually, my case was also NMO, which was confirmed by apoporine as well. So we had gone further and did all the scans, including the MRI contrast, which had shown these hyperintensities that were there on the orbits, and the optic neuritis was confirmed. And we also had undergone the visual evoked potential, which had shown the P100 delay that had confirmed the optic neuritis as well. So we had seen similar cases when I was presenting my grand round, that we have had a lot of NMO cases in our setting. Actually, when I traced, we had a case in 2021, 2022, and then I presented my grand round in 2023. So those were 3 grand rounds that we presented, and all the diagnoses were NMO aquaporin positive. That comes to the conclusion that Dr. Joseph was also saying, maybe epidemiologically in our setting, we see more NMO than MS. According to the literatures in up to date, MS is more common, but maybe in our setting, we might be having more NMO. So there was a plan to do a case series to show about the different clinical presentation. So apparently the patient that I had intact sensation. And then we can see the case today, instead of having bilateral optic neuritis, he's presenting with unilateral optic neuritis. So clinical features are different in certain patients. And we have a lot of cases. Maybe if we could share these cases and probably bring up a published document and see where we can help.
Thank you very much, Shani. Do we have anyone else with any comments, any questions, any experience that you would like to share before we close?
The only comment would be, since Shani now is is a new physician in town, we would love to hear cases from him. He must be having a lot of them.
Yes, Dr. Joseph, I am
Yeah,
planning to summarize them.
Yeah.
Actually, I might be having a case by the end of this month. I've sent him for some lab tests awaiting results, and it's an interesting case to share.
Sure.
I'll get back to you maybe by the end of this month.
That will be very impressive, my friends.
Yeah, that's amazing. I also see Conrad is here. I hope Conrad is also preparing something for us. So as I said last week, and on Tuesday, I shared a summary about the last year of AfroDX. So we've actually attained some milestones. It's been a year. So something that started as an idea with a lot of procrastination. I think it's only me and Joseph who know how much procrastination we did, because I think we planned on starting something like this since we were residents, and then it's only last year, that was 2024, maybe more than 2 years, almost 2 years after graduation. That's when we started discussing cases, just the two of us, and now it has grown. A number of people attending, and I think personally I should speak for myself. I think a lot of learning for me has taken place on this platform. I think